Anorectal malformation in bit details from Sabiston, Bailey and Schwartz. So first we'll cover up the Sabiston. Okay, very important topic. So anorectal malformation occur in 1 in 5,000 live birth. Okay. Most commonly, mainly, predominantly affect the male. Okay, but Schwartz said it is equally common in both sexes. But we take, if any doubt, we'll go with Sabiston. So it's bit more common in male. Okay. Then the most common defect. Okay. So in boys and girls it's a bit different. So imperforated anus with fistula is more common defect. Okay. And the fistula between the distal colon and urethra. Okay. In boys. In female it is vestibule of the vagina. Means the most common defect is imperforated anus with fistula, and the location of fistula is different in boys and in girls. So in boys, it is common in distal colon and urethra, and in girls vestibule of vagina. Okay. Now come to the timing. So there is a urogenital septum. Okay, it has to move distally to divide the cloaca into anterior urogenital sinus and posterior anorectal canal. Okay, so suppose this part, so there is a one. Okay, suppose this is the cloaca, so the one septum has to be formed. So anterior part will be urinary and the posterior part will be the GIT. Okay. So this has to be happen in 6th week. Okay. So the 6th week urorectal septum. This septum is called urorectum. Uro this part and rectum this part. So urorectal septum moves caudally to divide the cloaca into anterior urogenital sinus and posterior anorectal canal. Okay. Then complete or partial failure of the anal membrane will lead to the anal membrane or stenosis. Okay, if this membrane, this septum has not formed completely or partially, it will lead to the anal membrane or stenosis. Okay. So there is a perineal body. So perineal body is formed by the fusion of the cloacal fold between the anal and urogenital membrane. So remember, this is important. Okay, they will give you some other word. Okay, so perineal body is formed by the fusion of cloacal fold between the anal and urogenital membrane. Okay. Now come to the anatomic classification of anorectal anomaly. So it is based on the relationship to the levator ani musculature. Important MCQ. So this anatomical classification of anorectal anomaly divided into low, intermediate and high. Okay, this is low, intermediate and high. And it depends on the blind in rectal pouch in where in relationship with levator ani muscle. Important, this muscle is important. Okay, levator ani musculature. We are reading the anorectal malformation. Okay, catch this word ani. Okay, then later so when you diagnose this, so you have to take the lateral pelvic radiograph. Okay, lateral pelvic radiograph taken after infant is held upside down for several minutes. Okay, so keep the patient upside down and take the lateral pelvic radiograph. Okay, lateral pelvic radiograph. So it was used previously to determine most distal part of the rectal pouch, to locate where is the most distal part of rectal pouch. Okay. So if an anocutaneous fistula is observed anywhere on the perineal skin of the boy or external to hymen in a girl, it is low lesion. Okay, so anocutaneous fistula is indication of low lesion. This much you should know. Okay. Or rectal atresia is commonly associated with trisomy 21 Down syndrome. Okay, rectal atresia is associated with Down syndrome. Okay, so there is a classification of anorectal congenital anomaly of the anorectum. Okay, so it is divided, it is different for male and female. Okay, so we'll see what are the common in female and male. So cutaneous or perianal fistula can occur in female, and can occur in male. Okay, then imperforated anus without fistula. Okay, that can occur in both sexes, and rectal atresia can occur in both sexes. Okay, now come to the specific to female. So vestibular fistula occur in female, cloacal anomaly is occur in female, and then complex malformation occur in female. Okay, then in male, rectourethral fistula, bulbar prostatic, and rectobulbar neck fistula. Okay, so in female, in male, it is high chance that fistula is open with urinary tract. Okay, you can see. Okay. So this picture they give and they ask the anomaly. So this is imperforated anus with perianal fistula. Okay, and this anomaly has anorectoplasty with and without an osteotomy. This we will see later. Okay, this much you know. This is imperforated anus. There is no anal opening and there is a one fistula. Okay. Now come to the upper rectum being dilated and lower rectum consists of small anal canal. Okay, so this is okay. In this condition, you will see the upper rectum being dilated and lower rectum consists to small anal canal. Okay, then a persistent cloaca is defined as the rectum, vagina, and urethra all fused to form single common channel. Okay, so this is important. What is cloaca? So the anteriorly urethra, and then vagina, and then rectum all are fused to form a common channel. Okay, so in a girls, a single orifice in the perineum indicate cloaca. Okay, if two perineal orifice, there is urethra and vagina, the defect present as a high imperforated anus. So if two opening is there, so it is high imperforated anus, or less persistent, or less commonly persistent urogenital sinus. Okay. Then there is a vectral association. Okay, we'll tell in some other video what is vectral. Okay. Then absence of two or more vertebrae is associated with poor prognosis for bowel and bladder continence. Remember this one-liner. Okay, absence of two or more vertebrae associated with poor prognosis for bowel and bladder continence. Okay. Then vesico-ureteric reflex and hydronephrosis are the most common. Okay, vesico-ureteric reflex and hydronephrosis. Okay, so overall you can understand the genitourinary anomaly is most common. Okay, in which vesico-ureteric reflex and hydronephrosis. Okay. So higher the anorectal malformation, greater the frequency of associated urological anomaly. One-liner. Okay. Patient with persistent cloaca or rectovesical fistula, so there is a high likelihood of genitourinary anomaly. Okay, almost in 90%. Okay, persistent cloaca or rectovesical fistula. Okay, so cloaca is indicate higher anomaly, so high chance of genitourinary anomaly. Okay, in contrast, this is only 10% with low defect. Okay, 90% in higher and 10% in lower defect. Okay, so perineal or vestibular fistula may undergo primary single stage repair without colostomy. So anything is perineum or vestibular fistula is low means you don't have to do colostomy, you can repair with primary single stage repair without colostomy. Okay, if there is anal stenosis is present, you have to dilate. Okay, just serial dilatation will suffice. Okay, then anal opening is then when you call anteriorly placed anus, when anal opening is anterior to external sphincter. Remember, anal opening is anterior to external sphincter. Okay, with and there will be a small distance between the opening and the center of the external sphincter, and the perineal body is intact. Okay, so in this case, transposition anoplasty or mini posterior sagittal anorectoplasty has to be done. Okay, transposition anoplasty, transposition, because you have to bring it down to the normal position. Okay, and mini posterior sagittal anorectoplasty. Okay, so recto-urinary tract fistula with blind rectal pouch above the levator ani. Okay, so in this case, means we are talking about the high fistula. So you have to do initial diverting colostomy as a first part of the 3-stage reconstruction. So higher fistula has to repair in the 3 stage. The first stage will be colostomy. Okay, the second stage is the main step. It has to be done 3 to 6 months of age. Okay, in this we divide the recto-urinary or recto-vaginal fistula with pull through, okay, of the terminal rectal pouch. Okay, and this is known as the posterior sagittal anorectoplasty. Okay, and this is given by D. Varis and Pena. Important, remember this name. They ask Pena. Okay, this is procedure of choice. Okay, and the third stage you have to close the colostomy. Okay, because you form in the first step colostomy, the final stage will be closure of colostomy. Okay, and then anal dilatation begins 2 weeks after the anorectoplasty. So they ask this 2 weeks when you start the anal dilatation. Dilatation will be start after 2 week. Okay, so this flow chart is very important. They ask frequently. So any male newborn, okay, and anorectal malformation is present, you have to do perineal inspection, and within 24 hours, okay, you have to do spine, kidney ultrasound, spinal ultrasound. Okay, you have to examine sacrum, then you do urine analysis, then cardiac echo, and you have to rule out esophageal atresia. Means you have to look for vectoral anomaly. Okay, vectoral anomaly you have to look. Okay, then re-evaluate and cross table lateral film. This they ask. Okay, we don't take the upside down. Okay, we take cross table lateral film. Okay, cross table lateral film. Okay, then perianal fistula is present, then you have to do anoplasty. Okay, in one step. Then if the rectal gas below the coccyx and no associated defect, then PSAPR. Okay, posterior sagittal anorectoplasty with or without colostomy. Okay, and rectal gas above the coccyx means high fistula, high anomaly. So an associated defect. So you have to do first colostomy and flat bottom. Okay, flat bottom. This is also important. Okay. So few more points. So complication of anal rectal malformation is fecal continence is a major goal you have to achieve, but and constipation is most common sequelae. Okay. This is asked. Okay. Let's see what is given extra in Bailey. Few more points. Okay. So in Bailey we will look for this photo only, this picture. Okay. So the suppose if you are seeing the vagina. Okay, so we are talking about the female. So female only two condition. One is cloaca and other one is rectovestibular fistula in a girls. Okay. So now you look the common channel. If the common channel is present, means we are talking about the cloaca. All three join to form a common channel. Here they are opening separately. So this is rectovestibular fistula. Okay. In male there is a rectobulbar urethral fistula. You can see both are opening. No opening here. Okay. Let's see Schwartz what says. few more points. So this is picture of low imperforated anus in a male. Okay, so here the well developed buttocks in low imperforated anus, so buttocks will be fully developed. Okay. So in male patient with high imperforated anus, the rectum usually ends as a fistula in membranous urethra. Okay, so this they ask where they are ending membranous urethra. In female, high imperforated anus often occurs in the context of persistent cloaca. Okay, and in both male and female, low lesion associated with fistula in perineum. Already told you. So in male, fistula connect the median raphe of the scrotum and penis. In female, the fistula may end in the vestibule of the vagina. Okay. Pena classification, I told you this word is important. Pena. Okay. So here two important difference. The lowest portion of the prostatic urethra. Okay. If this fistula is present in the lowest portion of the prostatic urethra, it is called rectourethral bulbar fistula. If upper portion of the posterior urethra, okay, so this is rectourethral prostatic fistula. So lower portion bulbar, upper portion prostatic. Okay. So most frequent defect in a male is already told imperforated anus with rectourethral fistula. Okay, in female, imperforated anus with rectovestibular defect. Okay, so there is associated malformation. I told vectoral anomaly. Okay, so most common is urinary defect. You noticed. Okay, in a skeletal defect, most common is sacrum. In spinal cord is mainly T3 cord. Okay, and in GI esophageal atresia. Okay, these three important. In most common is genitourinary defect. Okay. Then in skeletal it is sacrum, spinal cord, mainly T3 cord, and GI esophageal atresia. Okay. So this patient, imperforated anus patient, are usually stable and rarely any urgency to intervene. Okay. So principal management center around the diagnosis of the type, that is the low or high, or any associated anomaly. Okay. These two things you have to keep in mind when you are planning the surgery. The fistula is high and low, this anomaly is high and low, or any associated anomaly is there or not. Okay. So you should take 24-hour time. And then you will notice the fistula on the skin is noted. So fistula take 24 hours to appear on the skin. Okay. So observe the neonate for some period of time before definitive surgery, just because you have to clear the fistula, whether fistula is present or not. Okay. So lateral abdominal radiograph taken with radio-opaque marker on the perineum. Okay. So in low lesion, okay, the only perineal operation is required without colostomy. Already told you. In low lesion, you no need to do colostomy, just do primary stage repair. Okay. In high lesion, first you have to do colostomy and followed by pull through procedure at 2 months. Okay. And Sabiston it is written 3 to 6 months. We will go with Sabiston. Okay. So posterior sagittal anorectoplasty, PSARP is procedure of choice described by Pena and Divaris. Okay. In this, the patient will be in prone jackknife position, and we divide the levator ani and external sphincter complex posteriorly midline. This is the key step of this PSARP. Okay. Divide the levator ani and external sphincter complex in midline posteriorly. Okay. And then we bring down the rectum, and later we reconstruct the muscle and suture the rectum with this muscle. Okay. So in high lesion, mainly main problem is incontinence. In lower lesion, main problem is constipation. Overall, constipation is more common. Okay. Thank you.